Okay. Ladies and gentlemen, welcome back. It's Thursday, April 30th, 2020. One day away from May, and we are still in lockdown. And I'm very excited to welcome Dr. David Brenner from UCSD Health. And gosh, it's a long title, Vice Chancellor of UC San Diego Health Sciences. David, thank you so much for taking time to join us on Bellevue TV. We go back to year one. So I'm here with my co-hosts, Alexis Dixon and Steve Chappell.
Hey guys. Hello, David.
Hello there. Thank you for hosting me. I appreciate it. Thank you, Amanda, for doing this. And we all miss you. Everyone misses seeing Amanda at Bella Vista.
We miss you guys. So I know a lot of people have been writing in, oh my gosh, David's going to be on. We have so many questions. I'm just going to jump right in and first ask, what is it like for you having to run a healthcare system in quarantine with the shutdown? And are there medical students? Are people going into institutes? What's it like right now on campus?
Yeah. So this is, in my long experience, this is completely unprecedented. I've never had to deal with anything like this. And I've been involved in the HIV epidemic. I've been involved, in various flu epidemics, and nothing has approached this. This is completely different from anything we've done before. It's a complete change in the paradigm. So for the medical students and the pharmacy students, they have gone exclusively onto online education. And we don't know how long we're going to do this. Even the students who are supposed to be in the hospital wards, we decided until we had a better handle on what was going on with COVID-19, we were going to take them out of the hospital. And this was a decision made by national organizations to do this. So the students are gone, they're learning from home, okay? Then in the hospital, we have dropped about 30–40% in our hospital census. And that was by design. We decided, along with the rest of California, not to do anything but emergency hospitalizations. And the reason we did this was twofold. One, we wanted to be ready for the surge. We were concerned at the enormous number of patients coming in with COVID-19. And we looked at our poor colleagues in New York and Detroit and New Orleans, and we said, we better be better ready. So we emptied out the hospital. The second is that we wanted to the best of our ability, practice being isolated at home, that we did not want anyone coming to work and being potentially exposed and getting infected by having to come to work. So we have switched as much as possible for our hospital to working from home, to eliminating everything but emergencies, trauma, interventions, catastrophes. But everyone else, we've been delayed. And that has been going on since early March. So we have a hospital that is understaffed, under hospitalized patients. We have an emergency department where people have been avoiding because they've been staying away from the hospital. And we have physicians and staff that are not being used to their maximum, that are home. So some people, like the intensive care unit patient, the intensive care unit is overworked, and some things like some surgical procedures are completely underworked, and some things like obstetrics, the babies come anyway, so that's the same as normal. So it's overworked, underworked, and appropriately worked. So nothing matches well, and that's where we are. And the next big adventure is how we're going to rebalance that to have more patients come in the hospital, provide better care for San Diego.
Which hospitals do you serve, for those who don't know?
Sure. So there are UCSD physicians at UCSD hospitals, which are the Hillcrest Hospital, which was the original UC San Diego hospital, actually where I trained as a fellow in 1985. Okay. and then there you go. My youngest child was born at UCSD Hillcrest. He's the only native. He's the only native Californian in the family. And then the La Jolla complex, Jacobs Medical Center, Salpeter Cardiovascular Center, Thornton, that complex. But in addition, there are UCSD physicians at other hospitals. In particular, all of the physicians at the VA San Diego Hospital are UCSD physicians, and nearly all of the physicians at Rady Children's Hospital San Diego are UCSD physicians.
What do you want San Diegans and to know about COVID-19? There's all this misinformation out there. There is, I mean, what to believe, what not to believe. From a fact-based scientific modality, what do people need to know about where we are right now?
Yeah. There are a couple of things. I think people in San Diego should in many ways be very pleased with themselves, because it was a public health intervention that I believe really prevented San Diego from having the same disastrous pandemic results as some cities comparable to us. So I think the idea of public health and social distancing and hand washing and limiting contacts has really made an enormous difference. And you know, it's a little bit of luck and a little bit of skill, and I think everyone in the government administration, local administration, should be very pleased with themselves. And I think that we have used what's the common term, flatten the curve, that instead of having an acute, very large peak that overwhelmed the health system, we had the slow, steady peak of about, in UCSD hospitals, about 30 patients per day. And our results, our outcomes have been very good. And also that our, the risk to health care providers has been very low, because we've had enough PPEs. PPEs refer to personal protective equipment, and we've had enough ventilators, and we had been able to handle patients in a very, you know, state-of-the-art, you know, evidence-based way. So I think all the hospitals in San Diego and all the people involved in government should be very pleased with themselves. I think as far as other things you should know, I think it might be worth, Amanda, to talk about testing and what testing means and what the implications are. Is that okay?
And go ahead, please.
Yeah. So okay. I know there are a lot of questions. We always say, where are the tests?
Yeah.
And then especially now, LA is the first major city in the United States. They're saying that is giving free testing to all of its.
Right. So let's go over the testing, what they mean.
Pardon, residents.
Okay. So let me just say what the testing means, and then let's talk about it. So there are two completely different types of tests you need to know about. Ready? There's going to be a quiz on this, Amanda, so pay attention.
Okay.
Okay. So there's what's called nucleic acid testing, which is abbreviated NAT. All right? Okay. That's a test. Okay, take this down. That's a test that will actually detect the presence of the virus. The COVID-19 virus, the SARS-CoV-2 virus, is an RNA virus, and there is a way in which you amplify the viral DNA in a very specific way that you can detect very, very low copy numbers of the virus. So how do you do that? The virus is not in your blood. It's not a blood test. The virus infects the lining of your lungs, which are not easy to get to. So how do you do that? The current technology is called a nasopharyngeal swab, or NP. You've probably seen that, NP swabs. So like a very long, bendy Q-tip is passed through your nose into your nasal pharynx, where your throat meets your nose, and it's swabbed up and down to collect that material, and then that material is sent to the lab where it's amplified, okay? And that's called a PCR test or a nucleic acid test. That tells you whether you have an active infection, yes or no. And that is the basis of all the diagnoses of COVID-19. Now, there are two ways of making that better. One is it's kind of painful to have a nasopharyngeal swab.
Yeah, and
the other is, you in particular, will be difficult.
It might be easier with you. I mean, you know.
No, I think it'd be difficult. and the other is can you do the test faster? And the answer to both is yes. Currently, there's comparison between the nasopharyngeal swab and saliva. We hope in the not too distant future, like in 2 weeks, we can convert from nasopharyngeal swab to saliva, which most of us can spit at will, and that's much easier to get than this nasopharyngeal brushing. So if we could show that, and there is several studies that have shown this already, if we can reproduce these, that the saliva is as good as nasopharyngeal swab, it'll make large screen testing much easier and much less painful, and it'd be much more, people much more willing to do it. Okay, so that's one thing. The other is, you might have heard this called a rapid test. The rapid test can be done at the POC, the point of care, and you can do it in 15 minutes. And we have one of those rapid tests at UC San Diego. So in 15 minutes, we can give you a result. And it's used when you need to know something immediately. For example, if someone comes in the hospital and you're worried what type of protection you need for that patient, you can tell in 15 minutes whether that patient has a COVID-19 infection and whether or not they need to be isolated or not. And so that's very useful. Most of us don't need to know in 15 minutes, but for those of us who do, it's a very useful test. Okay, so that's the first test. Ready? So that's the nucleic acid testing. Then what's become the hot topic in the last week has been the antibody testing, right? So every virus we get, we make an antibody response to. And if you have the antibody response, it means you have been exposed to that virus. And starting 2 weeks ago, we and other institutions can test you for your antibodies. So if someone was sick a month ago and they stayed home and they felt miserable for 2 weeks, they want to know, have I been infected with COVID-19, yes or no? We can answer that test now, and that's available now. So that will not tell you whether you have an active infection. You have to check for if you have antibodies, you don't have an active infection. But if you don't have antibodies, it doesn't tell you anything. So it doesn't give you any information. Okay. So COVID-19 infection, nucleic acid test. That you've already been exposed and are done, that would be the antibody test. But okay, the big question, the $64,000 question is having antibodies make you immune? That everyone wants to know.
Right. And so some saying no, that there's a possibility, right?
Right. With other coronaviruses, having antibodies means you have some immunity. Right. So they think you will, but there's no evidence that you do. And there's some very weak evidence from China that people got a second infection, which makes people very concerned. Okay. So do we have antibodies, and are they effective in immunity? So you want to know about the antibodies to know about the epidemiology, but you really want to know, are you now immune or not? And that we don't know yet. And now we have to follow out patients and see what happens to them. But as Amanda said, there's a little concern that maybe they're not protective, which would make us concerned about, for example, one of the therapies is, can you give convalescent serum from one patient to another patient who's sick and help them get better? Can you give the antibody? And if the antibodies aren't giving immunity, you're not going to help them at all. So that would be a therapy that wouldn't work. And also, you would want to know if you are at risk or not at risk. And so, as you know, when I was a child, everyone got exposed to chickenpox, and we're all immune for life. So some viruses give you immunity for life, and some, like hepatitis C and HIV, don't protect you. You're exposed and you don't get protected. You're not immune. So we don't know, but it'd be very, very important to figure out. And those are two tests.
What is the impact of drug abuse or alcoholism?
And I will be right back while you ask that question. Something arrived.
All right. What's the impact of drug abuse or alcoholism on revealing an accurate testing result? Does it somehow blur or affect negatively the test if I'm a drug user or alcoholic, or I'm drinking alcohol?
I don't know any study, but I can hypothesize that the nucleic acid test would be the same, because you're shedding the virus just like anyone else, but your immune system might be suppressed, and you might not have a positive antibody test because your immune system is not capable, because of the effects of drugs or alcohol on the immune system, to have a normal response, and therefore you might not see the response. So you might have been infected, done, but you don't have the proper antibody response to pick up. I should say that there is a concern, that there's some synergy between alcoholism and the symptoms of COVID-19, and there's some concerns that alcohol use disorder is made worse by social isolation, and that there should be a worry about that you are setting yourself up for a worse infection, and at the same time you are isolated and depressed, and therefore self-treating yourself with alcohol. So we have to be very careful about synergies like that, because we could make the pandemic worse if we're not careful.
Well, I'm kind of quarantined here. I can't even get out for beer. So I guess I'm killing two birds with one stone here.
How's that working for you?
It's working all too well.
Really?
That's
terrible.
In terms of beds in the hospitals, and you really are in charge of a lot of hospitals there, are some beds empty, or are they full? Or how close to capacity are we in terms of?
No, that's a really important point. And that the reason why we were told a month and a half ago to empty out the hospital was to the very, very serious concern that we'd have a surge and we'd overwhelm the healthcare system.
Yeah.
Fortunately, that did not happen. So all of the hospitals in San Diego have COVID-19 patients, but they all have empty beds because we're not doing the normal care that we usually do in order to prepare for a surge. And the question is now, how do we, since we seem to have been able to deal with the current number of patients, how do we provide COVID-19 healthcare and at the same time provide normal healthcare? And how do we make sure that the non-COVID-19 patients, all the other patients with cancer, with cardiovascular disease, with orthopedic problems, how do we care for them at the same time when we have COVID-19 patients? And part of the answer is to have isolated wards, separate the patients. The emergency rooms, for example, are completely separate. We have a COVID-19 entryway and we have everyone else entryway. And the same thing with the ICUs, the same thing with the regular floors. So we are planning, along with other hospitals in California, to start increasing the patients to come to the hospital. And you say, well, why are you doing it now? It turns out that things that were not urgent 6 weeks ago are now urgent. In other words, you could put off a lot of things for a week or two, right, and it's completely safe. But after a month, you are now concerned about patient welfare. Have you put off something needed to be done that is now adversely affecting the patient? And so at that point, you have to say, we need to figure out how to expand our services to provide outstanding health care while still being, alert to the needs of COVID-19 patients and still being hypervigilant about, we might still get a surge. We have to be very, very vigilant that we do not fill the hospital with patients that we could avoid it if we're going to get more COVID-19 patients. So it's a very, very difficult balancing act.
What are the signs of a possible surge, or what are the signs that you, or the protocol that you might be setting in front of yourself to see if that's going to happen? And what, if possible, what kind of a timeline are you thinking? Like late August, winter,
Yeah. So this has been extensively studied, and there are epidemiological modelers who have looked at the data every single day in San Diego County and have modeled different needs. And we have been flat for 4 weeks. There was, we have a constant stream of patients coming and going, but we have never got this surge and this spike or peak that comparable sized cities have gotten. No city in California has. It's really quite remarkable. So so what we do is we look and see if there's ever an uptick. If there's an uptick, we can close down everything but emergency surgeries in 2 days. So we can just keep very careful count. But we've been doing that for 6 weeks, and it's been constant. It's been constant flow. And I think that we've reached at the 6 week point where we really have to take care of additional diseases other than COVID-19 and make sure that people get good health care. And people have been avoiding the hospital. And one of the important points that maybe we can make in this video discussion is that the hospitals are safe. They're safe places. The testing is outstanding. Oh, let me give you one more example. We test every single patient who comes into the hospital, other than, trauma, every patient who's planned coming to the hospital, we test them for COVID-19 using the nucleic acid test. So every single patient, we know their status. And that was not true a couple weeks ago. So that was an enormous change in the way we take care of patients that really helps us maintain a safe environment in the hospital.
David, I have a question.
You're back.
And I left for a good reason. I promise you. Something up my sleeve. And it's not a beer like when we had Jerry Sanders on. You talked about how it's safe in the hospitals and it's safe for the workers. But I have a few friends that are on the front lines, and what's scary to them is when they come home from the hospital, if they've been exposed,
yes.
they have to, they can't hug or kiss their kids or their husband. Maybe they still like their husband, right? And,
they just choose not to. It's really,
and then they might have to self-quarantine. So on a night like last night, when I'm getting texts in the thread of all my girlfriends saying, oh my gosh, there's hundreds out at La Jolla Shores. What would you recommend to us? Should we still be staying indoors? What would be your best sage advice? Because I don't want my friends to not be stressed like at work and then come out of the, not the restaurant. This is not the restaurant. Come out of the hospital. Right. And have to hear this kind of news that we as people aren't being selfless. So where's that balance? What should we be doing?
Yeah. There's a couple points you raised. They're really interesting. First of all, about the first responders, they have done just an amazing job. I mean, no one had prepared them in medical school or nursing school for this. This was learning on the fly. I mean, this was completely unexpected, and we didn't train for this, and maybe there's a lesson there. But they've developed this amazing routine where they come in scrubs, from their home, and then they change into fresh scrubs at the hospital, and then they put on their PPEs and they prepare themselves for their day of work, and then when they come home, they undress in the garage and take off everything, and then take a hot shower and scrub down, and then change into fresh clothes. And we have a lot of data on our first responders, our hospital workers, particularly in the emergency medicine and the ICU, and the results are really good as far as people being safe. It's really, I can't tell you how pleased I am. I was, hoping for the best but preparing for the worst, because I know I can give you a comparison. It's not published that I used to be at Columbia University in New York, and I asked my friends what was going on there. Mm-hmm. And one of the examples they gave me that was so upsetting, half of the surgical residents tested positive for COVID-19. Half the surgical residents, none of our surgical residents. But that's the type of exposure that you have when you're overwhelmed that you don't have when you're in a more controlled environment. So that's the first thing. So the people have really figured out how to protect themselves and their patients. The second is that more than anything else, this has been a triumph of public health. There's not new medicines, there's not new respirators, new ventilators. It's really been the big advance has been doing so much better in public health. Everything we talked about, social distancing, washing your hands, wearing masks. And so when people, I'm so empathetic. I'm so getting so, stir crazy. I understand why people are so happy, but to go to the beach. But we are so at risk for a second peak that because we have virtually no herd immunity. I think 1% of San Diego might be immune. The other 99% of us are not. So we really can't afford to be exposed. And the infection rate's tremendous. The initial infection rate was the order of, they call it an R0 of 4. So in other words, each person would infect 4 more people. So you just go up exponentially so fast that any breakdown would be terrible. So I know you're trying to balance between, the economy and life versus, the safety of people. And it's a tough balance. Do you know the difference between what we did and what other countries did and what Sweden did? Are you familiar with this?
Sort of, but go ahead and tell us, because you're
really... if you can.
Even
So-
more
so-
than a man.
Laid out. Sweden, they just had like the old people kind of stay at home, right? The people
That's
that
right.
that would be-
Exactly.
Didn't they put them out on ice floes or something?
Yeah, that's right. Ice flows is the answer. So if we had more ice, we could do that. No, so that's exactly right. So they said, we're going to identify the vulnerable people. We're smart enough to understand who's vulnerable.
Right.
And then everyone else, we're going to let get exposed. Just normal daily interactions, not changing anything. Restaurants are open.
Right. No
Everything's
closure,
going.
school.
Schools, shopping, everything's open. And that way we'll get herd immunity and we'll protect the people most vulnerable. So what are the results been as of like yesterday? The results were that they have about 30% herd immunity, which is like an order of magnitude more than any place else. But they've had much, much higher deaths than the surrounding countries like Denmark and Finland and Norway. So they did not protect the vulnerable population. And you know, that's the result. They're better set for the next round, but people died who did not, comparable people did not die in other countries. It's really, I mean, this idea of, you know, you're familiar with the term utilitarianism, the idea that you'd probably try to maximize the most good for the most number of people. And that we're generally not a utilitarian country. We generally feel every person is valuable and every person is worth, and that we protect everyone, even if it makes, you know, even if it makes the average person's life a little more difficult, even if, you know, you have, you know, ramps for people who are disabled that is inconvenient. You say it's worth it for those few disabled people to be able to walk among everyone else, you know, and transport themselves among everyone else. So we're going to do that. So this idea of utilitarianism, which is what Sweden practiced, I find a little uncomfortable. And I think the results overall are disappointing.
And it's against the Hippocratic Oath, isn't it?
It is. You're supposed to be your advocate for every single patient. Every patient is valuable to his physician,
Yeah.
but that's the difference between, like, you know, utilitarianism and physicians. Physicians they're supposed to represent every single patient to get where they want to be.
David, let me ask you a question, please. The virus has certainly showcased physicians in a way that virtually demands their physicians, their scientists, their engineers, perhaps philosophers to bring the ethics. How does this inform us in how we need to train physicians for the future in an interdisciplinary kind of way? Because I believe the idea of standing in front of the class and lecturing to med students, those days have to be gone. I mean, these guys have to come out knowing science and engineering and pharmacology. I mean, all those things, how does that shift the making
That's
of
really interesting. I think that's really, really interesting question. So anyway, the founder of American medicine is William Osler. And he said that physicians need three things. Okay? Anyone want to try?
A brain.
Any guesses?
I read his history of
An
medicine.
ego,
but I
a
forgot
brain.
Just give me one. I'll be happy. I'll give you the other two.
Empathy.
That's very good. That's amazing. That's the one no one gets. Wow.
That's because I'm an empath. I'm an empath.
I see. No one gets that. The other two are easy.
The technical
action.
So skills and knowledge. They say you need knowledge, skills, and empathy. And any 2 out of 3 is not sufficient to be a good doctor.
Wow.
And I think, much as Amanda surprised me, I think that's the empathy part that's going to be re-emphasized, because you have to be willing to be courageous in some way, to go every day, as we discussed, and suit up and go to work. And if you don't have empathy, you probably don't want to do that. You probably want to do something else. And so I think that part is going to be re-emphasized. And how do you teach empathy? How do you teach physicians to be empathetic? How do you teach them also to practice self-empathy, so that they have self-compassion, so that they take care of themselves and don't let themselves get worn down. You know, there was, you know, as you saw in CNN or wherever you follow, there was a suicide among the New York emergency medicine physician who was considered, you know, one of the, you know, great empathetic physicians, but she's not taking care of herself, and, you know, she's not proper self compassion and commit suicide. You're so overwhelmed, and it's completely understandable. But we need to prepare people better for things like this. So I think that's important. The other is that there was, I think, a little bit of a dumbing down or desire to dumb down medicine. There was a feeling that everything is done by evidence-based medicine, and that you can follow protocols and figure out what to do, and you don't really have to know that much. Just have to know protocol. And this has shown that you have to be able to think on your feet. You have to be able to improvise. You have to be able to handle completely new data sets every day and incorporate that into your practice. So I think it's really, in a way, shown medicine at its best, that you really have to be able to adapt to a completely changing situation. So I'm so impressed with my colleagues, and particularly I talk to my friends in New York all the time, and how they figured out how to run a only COVID-19 hospital and have hundreds of patients on the ventilators, at all times. And they figured out these novel things, including, I don't know if you're familiar with this, proning patients. They found that if you flip patients onto their abdomen or off of their back, that it ventilates, in COVID-19, it ventilates the patients better, and they actually do better. And that was an empiric observation that then was adapted and now became, like, in days, standard of care. It used to take years to establish standard of care protocols, and these are now being developed in days.
Is that possibly because our understanding of this novel disease is different? I mean, the disease, our understanding of it might affect the kidneys in younger people in certain ways is different. The whole thing about proning, I think, came out of out of England and Italy, right. And it might affect the idea that COVID isn't just the lower lungs, or ventilators aren't quite the answer. Now, I obviously don't want anybody to think that I'm a doctor at all. So I wonder what you think in terms of
even before you ventilate, even before you require before you require a ventilator, the proning, even a person breathing spontaneously, they breathe better with COVID-19 prone, and they actually have proning teams that go through the hospital and flip patients around, and they found that they can avoid ventilators. But there was some data from ARDS, the classic acute respiratory distress syndrome that you can get from other types of diseases, that implied that there was something about proning that might be useful. But then it became really clear by observations, and then by making it standard of care and following and see how people did. And they can show each patient can be their own control. They have them lying on their back, and they have all the data on how they're breathing. And then when they prone them, they repeat it, and they can see a bump in their parameters. Each patient can be their own, and they can put them back and see if it goes back. So you can really, it's amazing how you can do serious observational studies, in real settings that improve patient care.
It sounds like turning over turtles. I don't want to, maybe that's
Is this because there's greater coordination within the medical field? And did this kind of coordination and sharing of information, did that exist before this? Or did the virus blow that wide open? And is there a possibility it will remain this way because it's so effective in patient care?
I think there are going to be changes that persist even after the pandemic is over. I think that, never waste a good crisis. And I think that there is a chance to really learn from what we've done and do better. The most obvious example, though, we have not discussed. The most obvious example is telemedicine. We did almost no telemedicine before the COVID-19 pandemic, because people like to see each other. It's just part of the culture. Even if they spent, an hour driving in, 30 minutes finding a parking place for a 15-minute doctor's appointment, and then driving home. Somehow that was just part of the culture. We just do that. And then you say, why are we doing that? How many times do we have to examine the patient? It's mostly a discussion, especially in patients So we went from, I forget, 50, something like 50 telemedicine events a week to like 5,000. We went up literally 100-fold. And And a lot of the patient care, particularly follow-up patients, can be done in telemedicine, and it's much more efficient, and it allows you to see more people quicker because it's not all setting up the rooms and moving all stuff around. So that has been an eye-opener that we could use that technology better.
And
You know,
David, I actually did it this week on Monday, just to chime in.
Yeah.
I had to make a last minute appointment, and it was funny because I said, okay, this is my first time and I'm doing the Zoom call, and it's funny, bless his heart, he's like, oh, I got to jump back off and get back on. And I'm like, okay, like he's new to this. And at the end, I go into my Bella Vista TV journalist mode, and I start asking him questions like, well, what do you think? You know, as a doctor, do you have a connection with your patients? And I think that was the concern, and that's always been the concern, is when you're going from reality to a virtual reality, are you going to lose that connection? And I know that you guys are working really hard, and we can maybe scoot over to that in a bit, with the Sanford Institute for Empathy and Compassion. Like you said, getting the students and the doctors to have that empathy. So I think that worry can be removed, that if we're doing telemedicine, you still can we're right here, you know, right, being empathetic on a virtual platform.
Right.
So,
before we get to that, and that's super important, I wanted to ask something I was getting at. When should a person go in to be checked at the hospital? Because some of this data coming out of England and Italy that I see is saying maybe it should be earlier, because if you could get tested, then you could do, I mean, this little thing that's sold out. I tried to get some today, where you put your finger in and you can find your blood oxygen level. And if you're tested, you're okay, you go home. Is that the mumbo jumbo, or is that something?
No. But I do think overall that the vast majority of people do fine. The vast majority of people stay at home, and actually telemedicine is useful for this. So if you are, think you have a cold, you would handle it in the usual way. You would stay home. You would keep yourself hydrated. You would not. You self-isolate. Maybe a little more rigorous self-isolating with COVID-19 than you would with cold. But you would practice sort of the normal, sensible things. So the way telemedicine falls in is that if it's persisting and you're starting to feel a little, punky, it might, at that point, a telemedicine interaction where you could describe your symptoms in a little more detail. And there's certain things that key us, if you're short of breath, that we want to see you. If your fever persists, and gets high, we want to see you. So there were things that would cue us. And so either telemedicine, and I suspect in the very, very near future, there'll be, I hate to say it, there'll be an app for this. There'll be something to help you through the logic. But the vast majority of people do great. Sorry, I had to say that. We'll do great. So we think that telemedicine, using mobile health, and then only using the physician, when it makes sense, can really decrease the spread of disease. And almost all of us will do well. The estimate is 90% plus of people will recoup at home completely and do fine. So we want to separate the 90% from the 10%. And then also, it's okay if you start feeling worse to then get another consult, to do another, as Amanda did, another telemedicine interaction. And if we think we need to bring you in, to bring you in. There's really no advantage of making a diagnosis for the vast majority of people. We can do the antibody test when you're recovered. I mean, and then see if you had COVID-19 for epidemiological reasons. But it's much safer to stay at home, recover if you don't need to. And I think there actually is an app on my phone. I'm not sure how it works, for an O2 oximeter. So I can actually get an estimate of my O2 saturation off my phone. So I think we'll have a series of apps like that will help us make, more rational decisions and interact by telemedicine to try to understand the data better.
Is that little gizmo, where you put your finger in, and it measures the oxygen in your blood miraculously, I think. Is that a good thing? Because I noticed that's the thing that's selling out across.
It is the probably the best single data point, objective data point about that you need an intervention. Usually you'll be short of breath before that drops. So you don't, but that provides really objective data. Some of us are nihilists and don't want to do anything, but that will give you data that you can actually use. And they found that people have been dropping their O2 saturation, before they get in trouble, and that's while they're getting in trouble. So it's good information to have.
Okay. Sorry, Amanda.
You want to talk? You want to talk about about the border and about issues about the border and COVID-19?
Yeah, Otay Mesa. I know that they brought up two zip codes in particular in San Diego, and one of them that's of major concern is Otay Mesa. And I believe there was one patient, because they're at capacity, that was it Scripps Chula Vista, maybe somewhere closer to the border, where they had to call in and say, hey, look, we're at capacity. We need to bring someone over to you guys. Yeah,
so it wasn't that they're in capacity. It was, so first of all, the quality of care, around the border, on both sides of the border, is not as good as it should be. The ability to get testing is not as good as it should be. The ability to triage appropriately is not as good as it should be. And most importantly, the infrastructure, particularly the ICU infrastructure, is not the same as elsewhere. So it's a real concern, and it will require, national intervention on both sides of the border to figure this out. But we really need, in any way we can, to help. And we've offered, for example, to do COVID-19 testing in our labs, if that's an issue. So that helps. The other concern is that the number of ventilators in the ICU beds are not as high. Okay. Modern hospitals have a very high ratio of ICU beds to regular beds, because so many things can be done as outpatients. Once you're in the hospital, the chance of being in ICU is higher. The old hospitals were like 10%, and 10-year-old hospital 20%. The newest hospitals are 40%. So it's really the ability to handle very sick patients changes dramatically. So that was a big issue. And then the final thing is this really, really subspecialized issues. And that's what the patient you're referring to, and without, violating any confidentiality. Right. There were some patients who have been shown to benefit by what's called ECMO. ECMO stands for extracorporeal oxygenation. It is like an artificial lung, where the blood is passed through, that it can be oxygenated and then returned by a pump back to the circulation. That is only available. There are very few places like UC San Diego. And there's a very small series of about patients with COVID-19, how they do with ECMO. And if you're very careful how you select the patients, like hopefully this patient that was transferred, you can actually make an enormous difference. You actually save a life by bringing them to, a health center like UC San Diego. And that is no way disrespectful to community hospitals. This is so specialized. You really don't want every hospital doing it. It's just not effective. But every now and then it makes a big difference. So everyone else, I just am very impressed with how well all the hospitals are doing, what great outcomes they're having, how well this has been the best interactions about, our CEO, Patty Mason, because all the other CEOs virtually every day, and they review what's needed and what's going on. That was not happening before. I think another good thing besides changing in healthcare that can come out of this is trying to be more effective as a community, as a community of healthcare. That we could be more effective in how we split up the work and not duplicate things and look out for different needs. And if one hospital is getting full. Can you divert to another hospital without making a big deal about it, but just saying that's best for the patient? It's not, it's not giving any credit or discredit. It just makes sense for community to do things like this.
That seems like I would like to think that's the new norm. David, I'm thinking as I listen to you speak, I think of the task of the physician and the people on the front line. And I'm wondering about a post corona environment where we will have to, as a community, hold a space for our physicians from just the pure exhaustion of having to deal with it. Are there any things, any systems, any conversations about how do we put systems in place to help our physician in a post-corona world?
Yeah, there is a lot of concern about sort of almost post-traumatic stress effect for physicians. If you can only sustain that intensity so long, and then you wear down. We've taken advantage. There are several mindfulness programs at UC San Diego, including what Amanda mentioned in the Sanford Institute for Empathy and Compassion, and they have online as well as in-person services to try to relax you and try for you to acknowledge and understand the stress you're under. And I think that will be intact going forward. I think that will become part of the culture, that we have to be protective of our colleagues, and of ourselves, because this type of continuous stress is very, very difficult. The closest I've ever been in a situation like this was at the beginning of the HIV/AIDS epidemic, where there was incredible stress on physicians, that a single mistake could be fatal, a single needle stick could be fatal, and there was no therapies, and so fortunately, HIV/AIDS is very non-contagious, and coronavirus is very contagious. So the stress in some ways is higher, even though the stakes are lower in that it may be 1% fatal or even less than that for young healthy people. But well, HIV/AIDS was at the time 100% fatal, but the risk of getting it was so much lower. But that type of stress, and you have to look out for people. And that was the only time I saw something like that was sort of comparable, where I was really worried about my colleagues and about that the difficulty in sustaining this type of intensity.
Mm-hmm. And I know a lot of, going back to my girlfriends last night, one of the comments was, there's burnout because so I think a lot of people, they don't realize the reality that our friends are walking in that are on the front lines. But it's also that anxiety, right? Because they've been waiting and waiting and waiting for weeks, and everyone's kind of nonchalantly saying like, oh, well, it's no big deal. Like, we flattened the curve. I'm like, yes, but you don't realize also the anxiety and the burnout of having to wait and just wait for the ball to drop.
Right.
So,
and the intensity of your daily work. I mean, everything has changed. I mean, the way you prepare for work each day is completely different. It's just very difficult to sustain that. Yes.
Yeah.
I've got a friend who is a scientist, and one of his questions is that we're not that far from San Onofre. If we were to have an issue with some kind of nuclear issue,
right,
and the medical community had to respond, what would that look like? Would that approximate what we're doing with Corona? Would that be a whole different set of protocols for the medical community? What would that be like?
It's so funny. According to the U.S. government analysis, they actually prepped with literally 15 to 1 as far as resources for a nuclear disaster compared to a pandemic. So they're actually they're more prepared for a dirty bomb or something like this than they are for a natural viral pandemic. So the prep is actually better. I mean, but it's similar intensity, and it's similar exposures and fear breaking down. That if you have a breakdown in your protocol, you'd be exposed, and be at risk, and that the physicians would be at risk. But people, for whatever reason, the people who are the futurists who try to, figured this out, got it completely wrong, and spent much more money prepping for a nuclear disaster than they did for a viral disaster. And now we know how easy it is for viral disasters. We know that there's so many viruses in animals that can skip to humans, and they're just millions of them, and it just takes just a few bad events to jump from a bat to whatever the intermediate host was to humans. So it just seems like we really miscalculated. But the other thing I thought you were going to say is that I imagine the stress is similar to people working with nuclear energy, that they know that they have to be on the guard all the time, and one screw up could be fatal, not only for them, but for their colleagues. And so I think that kind of stress, that when you're doing infectious agents or nuclear energy, that the protective gear and the way you have to prepare, it must be very similar. And also there must be incredible burnout. And then we've learned that you can't sustain this. You need a break. And the problem, I guess, with COVID-19, there's no break. I mean, you don't go home and you're isolated. I mean, at least people work nuclear energy, they go home and it's okay. They're not dealing with it. They can go away for a month, and you can't escape this. This is all encompassing. So that's why I think it's so unique.
Are we in a different world where science, technology, medicine is so much more important, perhaps? I mean, we spent trillions on a war, let's not get into that, but on 9/11 and preparing for terror. And here's something that we seem woefully unprepared for, even though it's the second or third or fourth SARS moment in the last decade. So do you think there'll be a change in the way people think? Like, golly, we need more Dr. David Brenners around and things like that.
Well, I don't think that's the solution, just the record. I don't think that's what we're going to come up with. But I do think that it was clear that we completely miscalculated. We meaning, the U.S. and there are all these, post-game analysis about how badly we did about preparing for PPEs and how, we weren't making enough, and how we didn't take into account how the chain, to get them from a factory to the patient would completely break down. It looks like there's so many things we should be doing different in the area of public health. That's why I feel it's a little bit, it's better to be lucky than smart. We just started a new school of public health, and we couldn't believe that, that all of a sudden it's become the most important thing. It was sort of like the stepchild of medicine, up until yesterday, and now it looks like it's going to be the critical component in healthcare. It is things like public health and testing populations and the chain of how things are connected and how you can provide infrastructure. So I think things are going to change, and even in research, I think there's going to be more research in population health and how you handle it, and how you do better for the underserved, how you make sure that that everyone gets screened, and like many diseases, COVID-19 has out of proportion affected people of color, people of lower socioeconomic class, and it really reflects badly on our infrastructure that people got lost in this, and so it's clear that we need to do better. That's why that I want our school of public health to really emphasize local issues, whether it's border health or whether it's taking care of populations in California, so that we really can use what you were mentioning, technology and science and data, to apply to public health problems. So that'll be new, and that's just happened, to be, that we sort of knew we were missing component in our academic medical center, and it wasn't so obvious until COVID-19 how important it was.
Might this make us?
Go ahead.
This is my last question. It's a touchy-feely question. Might this make us more empathic? What is the lessons of empathy to be learned from this within the medical profession, and maybe outside the medical profession? But what are the lessons of empathy that this is inviting us to consider?
I really think that if you walk around, and you need to walk outside for something, and you see who's wearing masks and who's not, you know, and you say, why are they wearing masks? And you know why they're wearing masks? It's not to protect them from you. Masks, the type of mask we're wearing, unless you're wearing a N95 respirator, it does not protect you from aerosol. What it does is it protects other people from you. So if you cough, it catches your cough. So you are wearing it because you are empathetic and you want to take care of your neighbors. And I think that is going to be reflected. I think our culture will change. I think we'll expect people to be responsive to their community and to behave in a way that's different than we're used to. I think there'll be a little bit of loss of individuality, of you know, just people acting out and whatever they think is best because it's not good for the community. So I think that there's a real lesson there, and the people who can practice the best community, you know, awareness are going to have the best outcomes. So I don't think that was appreciated going into this. And some cultures are more protective. I mean, you know, if I ever get to travel again, and go to China again, you will see a third of the people on, you know, on the subway at any given time wearing masks. It's not because they are afraid of their colleagues. It's because they have a cold, and that's the culture that you don't want to spread your cold, so you put on the mask. So I think there's a you know, a good teaching point there.
Yeah. Leo and I walked down the street, and Leo got a mask in Japan.
Yes.
So we always joke like, oh, he was ahead of the curve in the fashion.
That's right.
And we talk about it, that it prepared us for this whole pandemic, but we kind of simplify it just like that when we're walking down the street. He gets very angry when he sees people, especially adults, that aren't wearing masks. So now it's just like selfless, selfish.
Yeah, that's right.
And maybe that's oversimplifying, but the conversation among all of us has been, this is a true test of being selfless. And he says, why is it so hard here, Mom? I said, because we're a very egocentric culture.
Individualistic,
Individualistic. I love the idea of empathy as a behavior. And I just want to recognize that empathy is not a feeling, and it feels good to be empathic, but empathy is a behavior, and the behavior is the recognition that you're part of a broader ecosystem, that you belong to everyone, and you have an obligation and a responsibility to behave empathically. So I really thank you for saying that.
And that's not obvious, you know, under most circumstances. You kind of like feel it in the back of your mind, yeah, that's not polite, that's acting out, but it's not obvious until situations like this that really makes it clear what you need to do and what's the appropriate way to treat your fellow human being.
Anything
do you want to just
say to a pretty large audience listening, to the millions throughout the world?
Millions on the Mesa.
Millions.
Listening right now.
Yes. Do you want to very briefly say something about remdesivir or anything?
Sure.
Yes, that was going to be my question. Say that 3 times fast and then drink.
Remdesivir. So anyway, there has been, ever since you know, HIV/AIDS in 1982, there has been incredible interest in developing antiviral drugs, and they're very different than other types of drugs. They really aim at a very specific protein, you know, usually an enzyme in the virus that's so different than in the host that you can block the viral enzyme and the host doesn't care because the host doesn't anything like it, and that will prevent the virus from replicating. And some of the targets are called like polymerases, which the virus needs to replicate, and some are proteases, which the virus needs to break up its big proteins into useful little proteins that allow it to survive. And there are several different enzymes that are required for viral replication that are so different than mammalian enzymes that you can block them and not have very few side effects. That is new. I mean, relatively new. It used to be that people try very non-specific things, like giving things that would improve your immune system, like interferons. The things that are non-specific, just trying to get your own body working better in killing the virus. But with this new, with the highly active antivirals, that has been a breakthrough. And so they're developing this all the time, using a combination of high throughput screening just to see what works with large chemical libraries, or very specific, knowing the X-ray crystallography, the structure of the viral protein, so you get something that fits right in and blocks it. So there are different ways of doing this. And remdesivir was developed for Ebola. There were other people who were developing it, who were playing with it for other coronaviruses. But the idea was that they wanted to have a battery of drugs that look good for different types of viruses that they could take off the shelf and test immediately, not have to start from scratch with the original virus and try to and screen a whole library. So they said, okay, we're going to have some drugs that we can test immediately, and then we're going to go back to the library and see if there were other drugs also. But remdesivir was one that had some good activity against one virus, and they said maybe this will look like this virus and it'll work. So the criteria for viral effectiveness, are that the hospitalization is lower and the mortality is lower. And in both cases, it looks like remdesivir fits that. It's not 100%. It's like 30%. So it's clear there's a way to go before you have the perfect antiviral. And if anything is true, similar to other antivirals, it won't be one drug. It usually, there's a fear you'll develop resistance to mutations to one drug, but if you have two drugs, you can't develop simultaneous, resistance. So most, everything from HIV to HBV to HCV, hepatitis B virus, hepatitis C virus, human immune virus, they're all done by combinations that really have been effective. But this is the first hint that it's, what they say, it's not the beginning of the end, it's the end of the beginning, that there's something that works, and then you can make it better. So it's really was the proof of principle that there will be drugs for this.
So when they say like it's the new standard of care, or I've heard on the news they're saying it's putting us in the offense rather than the defense, that's what you're meaning, that we have hope.
Well, yeah, and also that probably there won't be any more sort of like placebo-controlled trials anymore. They'll have to say, well, the person needs remdesivir because that is better. That's better than nothing, and you have to compare your drug against remdesivir. And the feeling was that even the people who did badly with remdesivir, a lot of them got very late, and they were hoping that maybe if you got it earlier, the results would be even better. So they're trying to figure out the dose, the length of time, and whether getting it earlier will be effective. But it's really a good start. And if you look compared to 1982 is when I first took care of an AIDS patient, and 1989 was when the first drug came out, AZT, which is kind of crappy. That was 7 years, and you got a crappy drug. So this is a couple of weeks. Isn't that remarkable?
Wow.
Yeah.
Innovation.
UCSD is doing a lot of collaboration with SBP, LJI, UCSD, the Stanford Consortium. So it's amazing to see how our community is coming together.
Yeah.
I know you hit that word, sustainability. And I know we're running over time, but who doesn't want to stay on this call? I feel like smarter by osmosis every time.
As long as it works for you, Amanda, it's good for me.
Virtual osmosis. Are you guys okay staying on for a few more questions?
Sure.
Okay. So, do you have any hot dates or plans tonight during COVID?
Obviously, I can't go out.
This is not good for my love life.
I have a date with my, I bought an elliptical. That was my big breakdown. I decided to buy an elliptical. So I have an elliptical date coming up.
So the word is sustainability. And I think a lot of people are saying, what next? And this, I always go back to making it culturally relevant for myself and other moms or just people out there that can relate, and it resonates. A few months ago, I stopped and I said, my life is not sustainable. The way I'm living, I'm exhausted. I'm at the restaurant 7 days a week. I'm squeezing in world travel. I'm trying to be a full-time mom. And it's just, it's not sustainable. And so when we look at all of these systems and realizing they're not sustainable, education means that's archaic, right? Healthcare, our food supply, the food chain, we're seeing a breakdown in meat production, exercise, right? You have to buy an elliptical to exercise in your house. I'd love to go to the gym. People can't go surfing. And our political system. So
I can't play the violin.
Do you play the violin?
No, that was a joke.
Blonde moment. Think about sustainability. I think UCSD, and you're saying the School of Public Health, they're going to be that anchor for the community to come together. And I think UCSD and the Mesa and what we call our collective genius has really been a collaboration. So can you speak to sustainability and what you think about people coming together to solve these? Because now we got a lot of things to fix. It's just not the healthcare system, and one is connected to the other. I mean, we got to look at this holistically.
Yeah, I think we will get a new normal. I think we'll figure out the risk-benefit ratio and find some sweet spot that we can go forward, until there's a vaccine. I mean, once there's a vaccine, it'll be like polio. I mean, people used to avoid crowds in the 50s because of polio, and then once there's a vaccine, they went back to their normal life. So I think it'll be something like that. But in the meantime, I don't want to lose all this creativity and collaboration. I want to figure out how to foster it in a safe way, and if it involves, more Zoom meetings and less in-person meetings, so be it. If it involves, people, doing their experiments and then going home and analyzing their data, there are ways that we can.
Yeah, didn't someone bring home their cockroaches? Gary Robbins from the Union Tribune was telling us.
I thought he said he did. I thought he said he brought it home from the lab. Yeah. And he wanted to protect it. I think this whole idea of what David is talking about in terms of collaboration.
Treat each other well.
We lost you for a while.
You did. I know. I just said my internet is unstable. You have me again?
Yeah. Where the heck are you that your internet's unstable?
But to your point,
I'm at home.
Are you on UCSD guest?
No, I'm home. I went home for this. Anyway, I just want to think that we can continue the great collaboration across the Mesa and do really great things safely, and we can end up better for this. We can end up being more efficient, more effective, less wasteful, but less traveling, less driving. We can do better, and we can learn from this.
Yeah, and I think that's my hope. My hope is that the collaboration remains intact and it doesn't go back to silos. Right. And I want to ask a question, because thank you first of all for your gracious time with us and everything you've shared. But perhaps one of the ways to maintain collaboration is, in lieu of recognizing the single individual, is to recognize the teams that have come together and worked within an ecosystem to innovate. And I think how we recognize people versus individuals versus teams could be a way to foster sustained collaboration for higher levels of innovation.
Yeah, no, I think that's right. I think that that was evolving anyway. This has pushed us faster. There was an idea that you had to do team science and that to do really good projects. When I was a postdoc or a junior faculty member, me and a student and a technician, we'd run 5 gels and write a paper, and that was, and then we do the next paper, and that was it. Now, it takes a village. You need to be able to handle big data sets. You need to be able to generate, next generation sequencing data. You need to be able to analyze it with a computational biologist. You need to be able to see if it's relevant, in a model system. So to do an interesting paper now requires, half a dozen senior people and all their, technicians and students and postdocs working together. And so one of my jobs is to make sure all those people get acknowledged appropriately, that there's not this hierarchy where only one person gets credit for each, piece of work, but that we recognize that there are, a half a dozen or a dozen people needed for each really interesting piece of work, and that everyone who's contributed, that their contribution is noted, that they get promoted, that they get recognized, and that how archaic the universities are don't slow down the excitement about the science. So that's my job. I'll have to take care of that.
How many miles are you doing on the electrical?
There you go.
Well, it's also a time that we recognize you, and I don't want to burn my house down because I'm stuck here. So, David, we know that it was your birthday on Tuesday.
It was.
And this is what I call the gift that gives back.
Well, you use it for everyone's birthday?
No, because I can't drop it off to your house. So Leo gets to, Leo chose one.
Tell Leo he owes me big time.
Yeah. So we just
I can't even blow out the candles.
We want to wish you a happy birthday. So
Thank
on the
you.
count of 3, 1, 2, 3. Happy birthday to you. Happy birthday to you. Happy birthday, dear David. Happy birthday.
Happy birthday to
Okay.
All right, Amanda, don't give up your day job.
What's that? We're going to virtual.
Thank you. Are they out?
Happy birthday.
Thank you for spending.
Don't burn yourself because there's no ER for.
No, there is.
Oh,
The
there
ER
is.
is
Sorry
ready
about
for you, Amanda. You can feel free to burn yourself. The ER is safe. You have nothing to worry about. Okay. Thank you so much.
Good night.
Yeah. Any last words of advice? What we should be doing?
You should treat your neighbors and colleagues well, and realize how interdependent we are, and what a great community we have. Thank you.
Thank you.
I love you. Thank you,
It's
guys.
my pleasure. I love you all, guys. Thank you so much.
Amanda, before you
Happy
check, would you
birthday.
talk? Amanda, would you mention Bellevue TV that David's?
Yes.
work
So
will be on-
David is on today. He's streaming live, and then this will go on to Bellevue TV. We are fancy. We have a YouTube channel. You can subscribe and you can hit like, and then you will be able to see what we talked about today. So thank you guys so much. Lots
Thank
of
you.
exciting things coming next week. All right.
Everyone stay safe and healthy, okay?
Yeah.
Absolutely.
Thank you.
Thank you, David.
Bye.
Ciao.